Well, good evening. I want to welcome all of you who are attending the Sagis Dermpath Happy Hour in person. If you have any questions at all at any time, please feel free to address them to education@sagisdx.com, or you can email me directly, tdavis@sagisdx.com, and I think Cindy's going to type in those emails in the chat. For those of you who might be watching this later recorded, please feel free to use the same email addresses. It's with great pleasure that I introduce one of our newest colleagues at Sagis Diagnostics, Dr. Nicole Bender. Nicole is going to be hosting this week's session. Nicole's a dermatology-trained dermatopathologist. She went to med school at the University of Texas in Houston, and then subsequently did a dermatology residency at Medical College of Wisconsin, where she was chief resident. She then did a Dermpath fellowship at the University of Florida, kind of did a little tour around the United States before joining Sagis Diagnostics. Nicole is an excellent clinician, a very good dermatopathologist, and she has a particular interest in inpatient dermatology. So we look forward to hearing your cases. And without any further hesitation, I'll turn the floor over to Nicole. Nicole?
Thank you, Dr. Davis, for that wonderful introduction. Yes, today I will be covering several interesting cases. Hopefully they pique your curiosity. If anyone has any questions or has any follow-up, feel free to email me at nbender, N-B-E-N-D-E-R, @sagisdx.com. So let's get started. For the first case here, we have a thin shave of relatively unremarkable skin. So we are in our invisible dermatoses chapter. Invisible dermatoses is essentially a group of diseases which clinically have evident skin manifestations, but histologically are very subtle, or they're kind of hidden features. So some examples of this are vitiligo, macular amyloid, urticaria, telangiectatic macular xeruptiva perstans, and this entity that I'm showing you, this entity is very testable because while many of the invisible dermatoses require special stains or IHC to reach a diagnosis, this one does not. And so it really just requires you to remember to look for a specific finding and recognize it. And that finding is identifying these organisms, Malassezia furfura or Pityrosporum, to get you to the diagnosis of Tinea versicolor. So they are readily identifiable via H&E, and they don't require PAS to visualize. So this is why this is a very testable entity. They are frequently likened to spaghetti and meatballs that you can see. It's important to remember that these are commensal organisms. So you'll see them in a lot of different biopsies just incidentally. And so their presence doesn't always equal pathology, but the yeast forms usually are just found as commensal organisms. But when you see hyphal organisms, that usually means that this is pathologic. So we're in our Tinea versicolor diagnosis here. So if you're given a clinical image alongside the pathology, the differential diagnosis usually includes confluent inarticulate acanthosis and papillomatosis, CARP. CARP is also a very subtle diagnosis, but it would lack these organisms, and it has a greater degree of epidermal hyperplasia, papillomatosis, and basilar hyperpigmentation. So this is Tinea versicolor. Again, just to review, has the little spaghetti and meatballs. Okay, case number 2. We have a punch biopsy with a cystic structure in the center. If everyday practice, you're running out of time, you quickly scan the slide and you call it an epidermal inclusion cyst. or infundibular cyst, and move on, you'd be mostly correct. However, this is a little bit more unique than that. So it's important to always scrutinize cysts when you see them, its lining and its contents. In this case, the diagnosis is obvious once you get up close, because you can identify these pigmented hair shafts. These are terminal hair shafts, and they do contain pigment granules. So this is a pigmented follicular cyst. It's not to be confused with a vellus hair cyst. Vellus hair cysts contain vellus hairs. So these are much smaller, about at least a third the size of the terminal hair. And they also are not pigmented. So that's one way, if you're not sure about the size of the hairs, that vellus hairs aren't pigmented, while these are pigmented. So this is a pigmented follicular cyst. Has the normal infundibular cystic lining and the pigmented hair shafts. Case number 3. We have actually a large punch biopsy. This was actually an excision, punch excision. With a recent wound, you can see the scar here. But we have these structures in the dermis. The structures, they look like little tubules, and they're containing this kind of gray kind of amorphous substance within them. So kind of resembles sweat. So we're dealing with a sweat gland neoplasm. So at higher power, we should now be looking for decapitation secretion or the absence of that to tell if this is more apocrine or ecrine. And here we can easily see decapitation secretion with the snouting. That's apocrine secretion. So we should be in our apocrine adnexal neoplasm chapter at this point. So when we see multiple variably sized cysts, or sorry, ducts with apocrine secretion, this should really make you think about tubular apocrine adenoma, which that's what this is. So this is frequently set in kind of a fibrostroma, but it's also has these like just kind of, they call them red donuts in the dermis. So you just want to be looking for these variably sized apocrine cysts with set in a fibrostroma. The differential diagnosis for this is apocrine papillary cyst adenoma. That would also have areas akin to this, but it would also have areas that resemble an apocrine hydrocystoma. So those are the large kind of collapsed cysts that have apocrine differentiation as well. Papillary ecrine adenoma would show areas of intraluminal papillae and focal cribriform ducts. It would lack the apocrine secretion as well. And then adenoid cystic carcinoma, it has a mixture of patterns. So it will have some tubular, some solid, some cribriform architecture. And generally, the cells are more basaloid in appearance, but they can look quite bland. So that's in this differential as well. And then other ductal apocrine carcinomas, such as metastatic breast, would have more cytologic atypia, mitoses, and prominent nucleoli. These are really quite bland and nondescript. So this is a benign adnexal neoplasm. So this is tubular apocrine adenoma. Next case, we have a shave biopsy. And so here we can tell that we are near mucosal skin, if not irritated mucosal skin, because we're really lacking a horn and the granular layer is absent to attenuated. So we should be dealing with mucosal skin. This is vermilion lip, actually. So it's kind of like that in-between transitional zone. And we kind of have these somewhat elongated, bulbous greedy with basilar hyperpigmentation. So this is a labial melanotic macule. And on routine H&E sections, it can be very difficult to actually identify any melanocytes, especially at this site. But there are several. You see they're usually a little bit smaller with this hyperchromatic dark basaloid nucleus, kind of scattered. They're not always the pigmented cells. Usually, remember, melanocytes will distribute their pigment to the keratinocytes. So melanocytes themselves are not always pigmented, but you can see them scattered amongst the basilar hyperpigmentation here. So this is orolabial melanotic macule. Some people also call it a labial lentigo. When there's the absence of increased melanocytes, if there's an absence of increased melanocytes, some people will use the term melanocytic activation. This can be seen in things like smoker's melanosis. So that's in this differential diagnosis. And then the other thing would be if you have a dramatic increase in melanocytes where there's really no, there's more confluence of melanocytes, then that could be consistent with oral melanoma. So you have to think about those ones. But this is a pretty easy case to tell that there's not an increase in melanocytes, but they are still present. So this is orolabial melanotic macule. Okay. Next case, we have another small excision, actions in the dermis here. We, even just from low power, can tell that there's a proliferation in mature adipose tissue, but there also seems to be more going on, right? So we have a little bit of these interweaving kind of collagen. We also seem to have a little bit of this grayish substance up here with some cells. Excuse me. So let's figure out what else is going on. So we have the mature adipose tissue. We do have a bit of some myxoid stroma with a couple of these smaller kind of delicate spindle cells amongst them. And then we also have interwoven kind of collagen, this loose ropey collagen amongst that. So when we see this constellation of features, this is consistent with a spindle cell lipoma. That's the mature fat, bland spindle cells, myxoid stroma, and ropey collagen. They can all be in variable amounts. So there's even some that's the fat-free spindle cell lipoma. So they can really fool you, but this is a nice example that has all four components readily identifiable. This is also one of the CD34 positive tumors. To kind of help remind yourself that that's one of those. So the differential for this includes a pleomorphic lipoma, which looks pretty much identical, but it has scattered multinucleated cells that also floret cells, which kind of are these wreath-like multinucleated cells. Some people, or it's believed that Phaeohyphomycosis fibroma may be a variant of spindle cell lipoma. Atypical lipomatous tumor, aka well-differentiated liposarcoma, that would have a greater number of lipoblasts and mitoses. Lipoblast can be seen in spindle cell lipoma and pleomorphic lipoma, but should be like very rare. So the atypical lipomatous tumor would have a far greater number of lipoblasts. Other variants of lipoma would lack the spindle cell population, such as fibrolipoma. And then mammary type myofibroblastoma, the lipomatous variant, it usually has much more thickened and coarse collagen. These in spindle lipoma are more loose and kind of ropey, but hopefully you'd also get the clinical picture of a, this is coming from the chest of a young man. And then neurofibroma also has delicate spindle cells in a myxoid background, but the cells tend to be a little bit more wavy, while these are a little bit more oval in shape. And then the neurofibroma would largely lack the mature fat component and vessels. So what else? The fat forming or lipomatous variant of solitary fibrous tumor would also have more staghorn vessels, and that's STAT6 positive. So IHC would help you with that one. So this is spindle cell lipoma. Okay, next case. I'm just gonna take a drink. Okay. So here we have another shave biopsy. This looks now more like an inflammatory process. There is pseudoepitheliomatous hyperplasia overlying a robust inflammatory infiltrate. Our infiltrate is composed of numerous neutrophils, our little ant-like inflammatory cells amongst actual histiocytic granulomatous inflammation as well. And already you should be able to find the organisms. This is one of the easiest to test on because the organisms are readily identifiable since they are pigmented. So this entity that I'm showing you has both round yeast form and tubular hyphal forms. So most of the time they are found in these yeast forms. So you may just see the yeast forms, think, oh, chromoblastomycosis, and move on. But it's also really important for you to search for more of the hyphal forms so that you can help. Most of the time, this still needs to be differentiated via culture, but sometimes when you see the hyphal forms, then you can tell your clinician, that you favor Phaeohyphomycosis, which is what this is. Let's see if we can find some good hyphal forms. Mostly we're finding the yeast forms. And then there's some background pigment too. These are probably our best looking ones for hyphal forms. But this is an easy one to test on because you can see the organisms quite easily. And sometimes it's frequently that you'll find this with wood splinter as well. So you can always look for these organisms if you have a nice foreign body in place. But always remember to look for fungus when you have your pseudoepitheliomatous hyperplasia overlying suppurative granulomatous dermatitis. Remember, always look for fungus. And the best place to look for fungus is inside the multinucleated giant cells. Look for those. Okay. Next case. We have a shape biopsy, and there are apparent adnexal structures. So we're in our adnexal neoplasm chapter. We have prominent sebaceous lobules and kind of this central cystic follicular structure as well that has these buds of sebaceous lobules coming off, but there seems to be a little bit more to it than that. There's also areas of mature fat, and again, kind of there's somewhat, you have this illusion of circumscription with some kind of condensed collagen, some fibroplasia in the background. So when we have a mixture of both the epithelial and mesenchymal components, including sebaceous lobules, you should be thinking about folliculosebaceous cystic hamartoma. If this was only the epithelial components, especially with an epidermal connection, you should be thinking about trichofolliculoma, the sebaceous variant. And these entities are honestly very, very similar to one another. But just because it has these mesenchymal components, I personally think that this is a folliculosebaceous cystic hamartoma. So it's recognizing all of these components as well. And then a fibrofolliculoma would lack this sebaceous component and usually doesn't have quite as dramatic of a central dilated follicular structure. Not much else is in this differential. It's just recognizing all the components like spindle cell lipoma. Okay. Next case is one of my favorites. We have an incisional biopsy of a subcutaneous nodule. This came from the abdomen of a young woman. There are these irregular spaces that are filled with substance, so they're glands, and they're set in this kind of myxoid stroma, very like cellular myxoid stroma. And then there are some vessels, but then there's a lot of this deposited hemosiderin, and there are extravasated erythrocytes too. And then between the glands, there's some dermal fibrosis. So this is cutaneous endometriosis. So it's recognizing these irregular glands that really seem to be abnormal for the skin. And then finding this kind of deciduous background stroma with hemosiderin and extravasated erythrocytes. So cutaneous endometriosis. It's also nice to always have the history of, a young woman coming from, the umbilicus or from a previous abdominal surgery scar or something like that. So that can really help guide you too. The histologic differential diagnosis for this entity would be something like adenocarcinoma. That one you would usually have, atypical cells and mitoses. These are typical glands without any pleomorphism. Mitoses aren't apparent. Urachal duct cyst and omphalomyxenteric duct remnants would not have the background myxoid stroma. They tend to be a little bit more fibrous and they wouldn't have the hemorrhage and hemosiderin. But again, hopefully clinical would guide you for that as well. I haven't seen too many of those entities, but we see, on rare occasion, the cutaneous endometriosis. Okay, next case. We have a large punch biopsy with a large dermal proliferation of cells, trying to figure out what they are. Top to bottom, even infiltrating the fat, so probably something bad. These cells, they kind of almost resemble eccrine glands. There are areas where there's a little bit of an eosinophilic cuticle, and then these kind of cuboidal cells rimming them, but they're not in the perfect two-cell layer. The glands are, the little ducts are eccentrically placed. There's multi-layering of cells. There's some that are just little islands. There is pleomorphism. They're not perfect. Well, a lot of them are like small, monotonous, and cuboidal in shape. There is variation in nuclear size. There's some weird going on there. There are scattered mitotic figures. So this is an adenocarcinoma. Question is it from the skin or is it from a distant site? So immunohistochemistry is going to help you with that. And so this ended up being P63 negative, and the patient had a history of breast cancer. So this ended up being metastatic adenocarcinoma of breast origin. So this is where IHC is required, but recognizing that this is a malignant pattern given the architecture where this is really filling the entire dermis, infiltrating the fat, and then when you go down on higher power, you can see that it's ductal. So it's adenocarcinoma, and that the cells are malignant, but there's pleomorphism, they're hypochromatic, they're scattered mitosis. This is the metastatic adenocarcinoma. It's also important to remember that breast cancer is not always, when it goes to the skin, it's not always that single file infiltrating the dermis. There are different types of breast cancer, and so it can take on different forms. And so you should always think about it. It can be one of those foolers. Okay, next case. Another punch biopsy. Kind of a little underwhelming from this power. Just kind of looks a little busy. Top to bottom, there seems to be a little bit of something extra going on. So once we figure out what it is, we can see, yep, there's a cellular proliferation of very wavy, like spindled, kind of corkscrew-like cells with eosinophilic cytoplasm. And they are arranged somewhat in fascicles. So they resemble somewhat erector pili muscle, but not quite perfect. See, this is erector pili muscle. So you might think pilomatricoma, but it's not quite right for that, right? Those should really look exactly like the erector pili muscle. So this is dermatomyofibroma. So dermatomyofibroma resembles both dermatofibroma and pilolyoma in a way. The differential diagnosis is dermatofibroma. That wouldn't be as well arranged in fascicles and has a greater degree of collagen trapping. The cells too in dermatofibroma wouldn't be quite so corkscrewy. And for pilolyomyoma, it's really going to look more like the erector pillar muscle, which has more glassy cytoplasm, and the nuclei of that are much more kind of oval and have blunted ends. So, so that would be the difference for those ones. And then dermatomyofibroma can be patchy SMA positive, but is Desmond negative, whereas pilolyomyoma would be SMA and Desmond positive. And then neurofibroma, I guess, would be in the differential for this. It kind of has spindled cells that are wavy, set in a kind of pink background, but it wouldn't be arranged in fascicles like this either. And hopefully you would pick up how wavy the cells are to help you differentiate from neurofibroma. Neurofibroma will also have those cuttered mast cells as well, so you could try to use that as a clue. So this is dermatomyofibroma. Wavy corkscrew nuclei. Okay, next case. We have a large shave of an exoendophytic process. It's been traumatized or ulcerated. There's lots of hemorrhage. So again, it looks like we have another spindle cell proliferation. So these cells, they don't look particularly bad. There is, the spindle cell proliferation with these large pseudovascular spaces, I suppose we should call, because there is no true endothelial lining. It's just filled with hemorrhage. And then we have areas like this. So this is reminiscent of a typical dermatofibroma with collagen trapping. You've got these kind of delicate swirly cells, stellate and spindled. We've got some vessels, and then we have collagen trapping, exoendophytic lesion that has a thin epidermis on top. So this is a dermatofibroma aneurysmal type, also known as hemosiderotic dermatofibroma. It's also pretty common to be able to find multinucleated giant cells in this entity. And a lot of the times those will look kind of, or have like a wreath arrangement to them. Let's see if we can find some. This is at least one, but it's not. Here's maybe another. The cells are blending in with one another, but we start to see some multinucleated giant cells. Those are common in this, and then seeing little hemosiderin deposition. Sometimes you don't have as prominent of hemorrhage, and you'll just see more of the hemosiderin. The aneurysmal type is more of the one that has these large pseudovascular spaces. And it's important to recognize that these are truly pseudovascular spaces, because the histologic differential for this would be something like Kaposi sarcoma. So Kaposi sarcoma will be slightly more circumscribed. The vascular spaces will have endothelia. The cells will frequently have little empty spaces within them where they're trying to make a vascular channel, and IHC would differentiate the two very easily, as Kaposi would be CD31 positive or ERG positive, and then also HHV8 positive, while this entity would not stain for those. The DFSP is another thought for this. The cells for DFSP would be a lot more monotonous because that's fusion driven, while in DF, in dermatofibroma in general, the cells tend to have a lot more variability in their appearance, and that's totally normal for them. And even finding mitoses is totally normal to find that scattered. So that's not a feature of malignancy in these entities. It's actually a reassuring feature to find. So it's also pretty unusual to see hemorrhage and hemosiderin in a DFSP. Those don't tend to have that there. So that's another thing to really help you differentiate. But nodular calcium would be a good differential. So that would be one of those mimickers that would be trying to fool you, since it can have the hemorrhage inside of here. But really being able to recognize those areas of typical dermatofibroma with the collagen trapping, that's your clue. So this is dermatofibroma aneurysmal type. Okay, next case. We have another punch biopsy. Actions in the dermis. There's a collection of kind of large, irregular basophilic material that looks quite foreign to the skin. Closer in, it starts to get a little bit more granular in appearance. So this is calcium. And so you might say, oh, okay, this is calcinosis cutis, we're done right. But you should pay attention because there's something else here that you can see that's already in your view. And that's these cells here. These kind of shadow cells or ghost cells. So this is actually a pilomatricoma that's kind of old and at the end of its time, where it has largely calcified. And so pilomatricomas will frequently calcify and can even ossify in the skin. And they also frequently rupture and have granulomatous inflammation. So don't rely on just the presence of the basaloid aggregates for pilomatricoma. Don't get fooled for calcinosis cutis. Always check for ghost cells too, because you could be having an old pilomatricoma. Moving too fast, it's having to think. Okay, next. Next case. This isn't skin at all. This is the better version here. We recognize that this is a large organism. There is a mouth. There's skeletal muscle. There's a chitinous exoskeleton. There's innards of this large organism. The clue for what this organism is, to be able to speciate it, is this part. These are the spines, or setae is the other term for it. So recognizing these spines and noticing that they're pigmented. See that? So this is the botfly, that Dermatomyofibroma hominis that you'll see from Myiasis. This is that botfly. So here we just have the organism. If we have it with skin, the botfly tends to be very deeply situated in the dermis. So that's where you would find this organism, but it really is quite large. The differential for this, there's not a really great resource, at least that I'm aware of, for helping you differentiate the kind of arthropods, infestation, arachnids, worms, kind of things that I'm aware of. I'm not aware of them, so they can be quite challenging. But the differential for this would be like Tungiasis. That's from the sand flea. Tungiasis is around probably the same size as this, but it's usually present within the epidermis. It's kind of like the subcorneal area. And it would lack pigmented spines. So finding these is helpful. The site would also be helpful. The Tungiasis usually is on the feet and lower legs. Myiasis can really actually be anywhere. This one actually came from the scalp of the patient. Scabies would look quite similar to Tungiasis, but would be much, much, much smaller in size. So it's also found in the sternum cornea. But yeah, it can look like that. But again, it would also lack these spines. A tick would also be much smaller than this. It's embedded in the superficial to mid-dermis. And many times you'd only have tick mouth parts in your biopsy and are just left with that dense lymphohistiocytic inflammation with eosinophils. But I always get excited whenever I get to see bugs. And this was a good one. This is a botfly of Myiasis. with the pigmented spines. Next case, we have a shaved biopsy of a domed papule. There is an epithelial component here that resembles an epidermal inclusion cyst, but then there's more of this background gray substance. On higher power, yep, this gray substance looks a whole lot like mucin, but there's also a lot of these background delicate spindle cells. And there also are these there's also a prominent vascular component. So there's many of these small thin-walled vessels. So this is a cutaneous myxoma, aka superficial angiomyxoma. It's characterized by these bland stellate and spindle cells set within a dermal mucin pool. There are many thin-walled small blood vessels, and there are frequently neutrophils scattered around. And you can have mast cells in this as well, but mast cells usually just follow mucin wherever. These can be just merely solitary and reactive, or they can be seen in Carney complex. The histologic differential diagnosis for this includes aggressive angiomyxoma, but that would be much larger and usually deeply situated. Focal cutaneous mucinosis would have fewer blood vessels and also doesn't usually contain neutrophils or epithelial components. Myxoid neurofibroma also lacks the epithelial component like this, and would also usually lack neutrophils. And myxoid neurofibroma would be S100 positive. This can be S100 positive in a minority of cases, but it is EMA negative. So that can be something else that can help differentiate it with neurofibroma, because that can have some scattered neuronal components like axons, but this would lack that. Nerve sheath myxoma, formerly known as myxoid neurophaeohyphomycosis, doesn't have prominent vessels, neutrophils, or an epithelial component either. And usually the cells are more epithelioid than spindled. And a lot of the times it wouldn't be kind of this large dermal pool. That would be a little bit more vesicular that the mucin's in. So this is cutaneous myxoma, aka superficial angiomyxoma. And then this is just a colloidal iron stain. Beautiful, highlighting the mucin. All right, and then our last case, we have another shade biopsy of a quite basaloid process. There is some reactive epidermal hyperplasia kind of overlying this dense, diffuse nodule sheets of basaloid cells. So we have to go up close and see. And overall, the cells, they really are approaching the epidermis, almost consuming it. So they're kind of going into the epidermis too. The cells themselves are very basaloid, hyperchromatic. There's numerous scattered mitoses. There's necrosis. The cells are quite large. So one of the ways that I had to cheat to tell if cells are large or not is comparing them to nearby cells. So comparing them a lot of the times to nearby nuclei of keratinocytes, as well as nuclei of endothelial cells. So these cells are large because they are roughly the same size as a keratinocyte or endothelial nucleus, or larger. So these are large cells. And so we've got sheets of large cells. So we have to do immunohistochemistry in essence to actually tell us what this is. And just in general, I'll tell you what the immunophenotype is. It's CD3 positive, CD20 negative, CD4 positive, CD8 negative, and CD30 positive. So with this immunophenotypic profile, it is CD30 positive lymphoproliferative disorder. This umbrella term includes CD30 positive large cell transformation of mycosis fungoides, lymphomatoid papulosis, and anaplastic large cell lymphoma, which clinically this case fit best with. So there's no immunohistological staining that allows a precise histopathologic differentiation between lymphomatoid papulosis and anaplastic large cell lymphoma. However, ALCL does require that at least 75% of the neoplastic cells are positive for CD30. So a lesser degree could be seen in LYP or large cell transformation of MF. So that's one way that they could, a test giver could try to pigeonhole you into giving a diagnosis, is by giving you a CD30 that has greater than 75% of the neoplastic cells. That could be ALCL. If it's less than that, then it's likely not ALCL. This, most of the time, we just have to give the umbrella, and clinically, you have to differentiate what this is. But IHC is what helps you differentiate that. There's not great clues on H&E alone. So those are all the cases I have for you. I hope you enjoyed them. Again, if anyone has any questions or follow-up, feel free to email me. My email again is nbender@sagisdx.com. I hope you guys have a great night, and let me know what you think. Thanks.
Thanks so much, Nicole. Really do appreciate it. Again, if you have any questions, please let us know. Thanks for tuning in. And next week, Dr. Rincon, one of our other new associates at Sagis Diagnostics, will also be presenting a group of cases. Links should go out soon. Thanks a lot. Have a good evening. Bye-bye.